Welcome. This video provides a comprehensive guide to interpreting full lipid profiles, strictly following the current NICE UK cardiovascular prevention guidelines. Understanding your lipid profile is vital for assessing cardiovascular disease risk and guiding prevention strategies as outlined by NICE. We'll break down the full lipid profile components and align their interpretation with the latest NICE guidelines for effective CVD risk management. The key markers in your lipid profile are total cholesterol, LDL-C, HDL-C, non-HDL-C, and triglycerides. These all play a role in determining your cardiovascular risk. Let's start with total cholesterol and low-density lipoprotein cholesterol, or LDL-C. Total cholesterol's normal reference range is typically below 5 millimoles per liter. High TC levels necessitate further risk stratification, often using the QRISK-3 tool. For primary prevention, the goal is often to reduce LDL-C, while secondary prevention mandates intensive lowering due to established disease. Treatment initiation depends on risk. In primary prevention, a QRISK-3 score of 10% or more suggests statin consideration. For secondary prevention, treatment is mandatory, focusing on high-intensity statins to target specific high-risk thresholds. Next, we examine non-HDL cholesterol, a crucial measure preferred by NICE. Non-HDL-C is total cholesterol minus HDL-C. NICE emphasizes a non-HDL-C reduction of 40% or more, regardless of baseline levels, particularly when initiating therapy. Abnormal non-HDL-C values significantly increase cardiovascular risk. If initial treatment fails, intensification is required, often involving adding ezetimibe or other lipid-lowering therapies. Now let's look at HDL cholesterol, triglycerides, and important ratios. HDL-C is often called good cholesterol due to its protective role. While normal ranges vary, high levels are generally desirable, though current guidelines focus less on treating low HDL-C. Normal fasting triglycerides are typically below 1.7 millimoles per liter. Raised TGs require lifestyle modification and addressing secondary causes. Very high TGs warrant consideration of fibrates to prevent pancreatitis. The total cholesterol to HDL ratio is a quick risk indicator, with a lower value suggesting better cardiovascular health. However, it should be used in conjunction with the full lipid profile and QRISK-3. The NICE guidelines integrate lipid profile results with formal risk assessment tools to determine treatment pathways. The QRISK-3 tool calculates the 10-year cardiovascular risk. NICE recommends discussing statin initiation when this risk reaches 10% or more, using statins as the first-line drug therapy. For high-risk groups such as those with chronic kidney disease, diabetes, or established CVD, the lipid targets are more aggressive, and treatment is initiated irrespective of QRISK-3 scores. Let's cover next steps for advanced cases and monitoring protocols. Consider adding ezetimibe if the 40% non-HDL reduction target is not met with a maximally tolerated statin dose. Specialist referral may be needed for complex dyslipidaemias. Lipid profiles should be monitored 3 months after starting or changing treatment, and then usually annually. Always exclude secondary causes of dyslipidemia and intensify treatment if targets are consistently missed. In summary, interpreting lipid profiles requires combining TC, LDL-C, non-HDL-C, and triglycerides with formal risk assessment, QRISK-3, to guide statin therapy, aiming for at least a 40% non-HDL reduction per NICE guidelines.